Okay, we're going through electrical conduction through the heart, electrocardiogram basics, and the relationship to mechanical movements through the heart. Electrical conduction of myocardial cells begins in the cells of the SA node, which are autorhythmic cells. They send electrical signals to contractile cells through intercalciated discs with gap junctions to allow the flow of ions all in one direction through the heart tissue. Myocardial contractile cells have a long refractory period, which does not allow them to fire again until very close to when muscle relaxation takes place. This allows the flow of ions and electricity to be all in one direction. The electrical conduction through the heart begins in the SA node, travels through internodal pathways to the AV bundle, down the septum of the heart, through the bundle branches, out to the lateral sides of the heart through Purkinje fibers. This relates to an electrocardiogram in that the P wave represents an electrical signal for atrial contraction. The QRS segment represents an electrical signal for ventricular contraction. These contractions actually take place in the PR segment for the atrial contraction and through the ST segment for ventricular contraction. Einthoven's triangle is a good way for us to understand which lead and which direction we're looking at through the heart. I always relate it to the right arm first. So right to left is 1 across your chest. And then the right arm to the left leg is 2, followed by the left arm to the left leg, which is 3. Here are a couple of examples of electrocardiograms that I've taken through my job. If we look over here in lead 2, we see ST segment depression, and B2 is ST elevation. ST elevated myocardial infarction, STEMI. So this is a anteroseptal. These are the anterior leads here on the for the septal area of the heart. So that's a myocardial infarction. This here is supraventricular tachycardia. If you look at the heart rate here, it's at 240. That's pretty fast. And then this one here is called atrial flutter. So the atria is firing 4 times for every time that the ventricles are firing. This is kind of how electrocardiograms can be useful in a diagnostical way to help us understand a little bit more about what's happening in the heart.
Hello, everybody. Today we're going to be talking about the mechanics of the cardiac cycle, specifically looking at pressure. So here we can see that pressure of the ventricle on the Wiggins diagram, and we can also see the different stages of the cardiac cycle. We're going to be looking at each one a little bit closer, starting with the atrial systole. So in atrial systole, the AV valve is open, which means that the atrial contraction can still push a little bit of extra blood into the ventricle, so there's still a little bit of blood flow. There's a little bit of a difference in pressure, but not really enough to be significant. However, once we get into isovolumic ventricular contraction, that's going to push the AV valve closed so that there's no more blood entering. And when that AV valve closes, that's where you're going to hear the first dub of the heartbeat right there. And when that happens, the pressure in the ventricle is going to increase, but the volume is not going to change. You can see that big jump in pressure starting right there. And we get into ventricular systole. So the pressure is rising. It's going to exceed the pressure in the arteries, which is going to push the blood from the ventricle into the aorta. You can see the aorta pressure is changing right there as well. And so they're just going to kind of move together until the pressure in the ventricle is falling, and therefore it's lower than the pressure in the arteries. It's going to have a little bit of blood flow back into it, which is going to close that semilunar valve. You can see right there the dicrotic notch. That is where that semilunar valve closes. So blood can no longer move between the artery and the ventricle. And that's where you're going to get the second dub in the heartbeat right there. So that's early ventricular diastole. During late ventricular diastole, everything is somewhat relaxed and the valves can open again in the AV valve so that blood can fill passively. It can move through the atrium into the ventricle and that volume can change again. Pressure isn't going to be changing during this part, just the volume. But once that is filled back up again, the cycle is going to start again with the atrial systole, and then you're going to go through another cardiac cycle and it's just going to repeat. So you can see the relationship through the volume and the pressure right here. So specifically looking at the end diastolic volume and the end systolic volume, you can see at the end diastolic volume, the volume is at its maximum. It's not going to increase from there, but the pressure is going to be very low until that pressure increases and forces the blood out of the ventricle. When that happens, it's going to continue to force it out until that pressure reaches a point where it can fall. The volume has reached sort of its minimum for the time, and that's where you get the end systolic volume. The difference between the end diastolic volume and the end systolic volume is going to give you your stroke volume. You can see its definition right here, where the stroke volume is the amount of blood pumped out by one ventricle during a contraction. It's a pretty easy equation. That stroke volume is going to affect the cardiac output, because the cardiac output is the volume of blood pumped by a ventricle in a given amount of time. You can see right there that it's affected by both heart rate and by stroke volume. And it can vary depending on people and circumstances that they're in at the moment, but the average for a person is about 5 liters per minute, which is a pretty good amount of blood.
I'm going to talk about how the sympathetic nervous system affects cardiac output. So as we all know, norepinephrine will touch the beta receptors. For the sympathetic nervous system, it affects the alpha receptors. So the beta receptors will cause a cyclic AMP cascade to happen. This, in turn, will phosphorylate the phospholambin and the Ca2 plus channels. Once these are phosphorylated, phospholambin will affect the Ca2 plus ATPase involved with the sarcoplasmic reticulum. The Ca2 plus voltage-gated channels and the Ca2 plus ATPase are both involved with calcium input and output. This means that calcium, due to this activation, will become more put in and taken out of the myosin and actin fibers faster. Additionally, another effect of norepinephrine is that the troponin has a higher affinity for the calcium. That means tropomyosin is more readily available for it to be bound to by the myosin heads, which means that contractility and the force of contractions are increased. Another effect of norepinephrine is that the action potential is also changed. So a normal action potential, well, for this example, let's say sits around -60, happens around -40. For the parasympathetic, it is lower. You see it happens around 70, it sits around 70 and happens around the same time, but now there's a longer time for the action potential to actually occur. For the sympathetic, action potential, the cell sits higher around -50, which means now there's less time for action potential to occur, meaning action potentials occur more frequently and faster. So cardiac output, how is this affected? We know that heart rate is increased. Well, now we also know that contractility is increased and the force of the contraction is also increased due to the Frank-Starling law. The Frank-Starling law says as contractility increases and the force of the contraction increases and diastolic volume, right here, is also increased. These factors all affect stroke volume. Now that stroke volume is increased and heart rate is increased, we know that cardiac and rate of depolarization is also increased. We'll know that cardiac output will be increased as well.